Welcome. In this lecture, we'll be discussing demyelinating diseases. These will be the primary diseases covered in this lecture, with the first three, highlighted in green, covering the central nervous system pathologies, and the last one, CMT disease, highlighted in red, will be covering the only peripheral nervous system pathology in this lecture. Please note that the two most common and highest yield for the purposes of exams, multiple sclerosis and Guillain-Barré syndrome, are covered in separate videos and will not be discussed in great length in this lecture. Let's first discuss Neuromyelitis Optica, also known as NMO. This is secondary to autoantibodies against aquaporin 4, which is a water channel protein found on osteocytes in both the brain and the spinal cord. This helps to move water in and out of the brain, regulating brain swelling and even supporting the blood-brain barrier. Production of these autoantibodies can lead to astrocyte injury, complement-mediated inflammation, hence the itis portion in the name, and destruction of myelin and axons, especially in two locations, the optic nerves and the spinal cord. The way that I've always remembered this pathology is with the name. Myelitis helps to remind you that this is inflammation of the spinal cord, and optica helps to remind me that this is also due to inflammation of the optic nerves. That is how these individuals are going to present. Now, furthermore, since NMO is an autoimmune disease, this is going to be more commonly seen in women, more specifically African or Asian women. This typically presents as a relapsing or remitting course, meaning that this course comes and goes throughout an individual's life. This is very common or very similar in presentation to multiple sclerosis. You should note that for board exam purposes, NMO and multiple sclerosis are commonly tested against one another because they are commonly misdiagnosed since they present so similarly. So let's go over the presentation of NMO, and then we'll compare this to multiple sclerosis in the upcoming slides. NMO, we already know, is going to be due to inflammation of the optic nerves and of the spinal cord. Optic nerve inflammation, also known as optic neuritis, will be bilateral because the autoantibodies affect the channels, the aquaporin channels, on both optic nerves. This will result in bilateral painful eye movements, blurry vision, and on physical exam, you may have a swollen optic disc, noted here. See how large that diameter is for that optic disc? That implores that this may be optic neuritis. You can also see transverse myelitis or inflammation of the spinal cord resulting in sensory changes, limb weakness, or even urinary incontinence. Now, NMO is commonly compared to MS, but it differs in the fact that this has bilateral optic neuritis. Bilateral optic neuritis is a very unique presentation typically seen in NMO. Also, this optic neuritis typically lasts longer than seen in multiple sclerosis. This also commonly presents with both optic neuritis and spinal cord myelitis, hence the name Neuromyelitis Optica, at the exact same time, each time. Sometimes we can get extension of the spinal cord lesions, often involving the brainstem. This can lead to intractable nausea, vomiting, or even hiccups. Now, like multiple sclerosis, the image of choice is going to be an MRI of the brain and spinal cord. And with that, we're going to see inflammation. Inflammation of the optic nerves and inflammation of the spinal cord, typically greater than 3 segments or 3 vertebral segments seen. This is an individual with NMO, and what we can see here is we have inflammation from around here to down here, affecting 1, 2, 3, 4, maybe even 5 vertebral segments. Typically with NMO, we see greater than 3, and that is a hallmark finding on MRI imaging. Sometimes we can also get serum or CSF findings to show us those autoantibodies, those aquaporin 4 channel IgG antibodies. Now, because NMO is an inflammation, the treatment in acute setting is going to be anti-inflammatory. Typically with IV steroids, we typically try these for roughly 3, maybe 4 days. And if there's not responsive to treatment, then we can try plasmapheresis in order to remove those autoantibodies. The reason why we do this is because of the fact that compared to multiple sclerosis, NMO is actually far more severe and symptomatic presentation is actually much worse. Thus, we do not want to wait for them to respond to steroids. We give them a trial, and if they do not respond in time, then we do a plasmapheresis in order to clear out their blood. For chronic treatment purposes, we typically need immunosuppressant. This can either be with azathioprine or rituximab. Now, like I said, NMO is classically compared to multiple sclerosis. And this is because they have some similarities. Now, there's a whole lecture dedicated to multiple sclerosis, which I highly implore you to watch and then compare to NMO, but there are some things that I will emphasize. Typically, NMO affects Asian or African females, where MS affects Caucasian females. Typically, NMO has bilateral optic neuritis, where MS will have monocular optic neuritis. We'll also see other ocular issues with multiple sclerosis, such as nystagmus or intranuclear ophthalmoplegia. With multiple sclerosis, we typically have very unique presentations with periventricular lesions or white matter lesions around the ventricles. And we typically also have oligoclonal bands on CSF findings. Please note that we do not have those lesions seen on imaging on NMO, and there are no oligoclonal bands noted in NMO either. The next one we'll talk about is progressive multifocal leukoencephalopathy, also known as PML. This is due to reactivation of JC virus in typically immunocompromised patients, like those with HIV or who are on immunosuppressants. Now, the JC virus is a common virus that most people get in childhood and usually stays harmless and inactive in the body. But sometimes, in the setting of immunocompromised patients, this virus can activate and infects and destroys oligodendrites, the cells that make up myelin in the central nervous system. Hence, this is a central nervous system demyelinating syndrome. This leads to widespread demyelination in the brain, causing progressive neurologic decline, hence the name. Thus, typically, with people with PML, we expect a CD4 count less than 200. We can also see this with people on immunosuppressant treatment, which we will talk about in the upcoming slides what that treatment is. This typically affects both the occipital and parietal lobes. Now, the symptom presentation is very unique in the fact that it is rapidly progressive. The average lifespan of someone with PML is only 3 months. These symptoms typically start off mild and then get worse over the course of days to weeks. Now, the presentation itself can vary, but usually you'll see some sort of confusion and or weakness that starts out very mild, and then in the next week or two, it'll be very, very severe and detrimental. You can also see stuff like dysarthria, dysphagia, vision changes, ataxia or imbalance. Even seizures can sometimes be seen. But the big takeaway is that this is rapidly progressive. Now, imaging purposes, we typically require an MRI brain. And with this, we see a very unique presentation. We see focal white matter lesions with no enhancement or edema. This is a common image that you should know for your exams. Please note that these white matter lesions that we see here are focal in the sense that they are only occupying certain areas of the brain. We can sometimes also get an LP, and that can sometimes be positive for the JC virus itself if it is still active. Now, sadly, for PML, there is no cure, and a lot of the treatment is going to be supportive. If HIV is suspected, then these individuals can be placed on antiretroviral therapy, and that might prolong their life. Sometimes, like I mentioned, this can also be caused by immunosuppressant therapy. The two big immunosuppressant therapies is going to be natalizumab and rituximab, and this is very commonly tested for your board purposes. Now, natalizumab is a drug used in chronic MS. Rituximab is used for many diseases and suppresses the immune system. Both of these can increase the risk for JC virus, which is an opportunistic demyelinating disease. Now, but prior to starting these treatments, for whatever purpose, either multiple sclerosis, and you'll see sometimes rituximab is very commonly used for some sort of heme cancers or oncologic cancers as well. Prior to treatment, you need to screen for the virus. If the virus comes back positive, they are not able to get these treatments. If it comes back negative, then during the treatment, we continue to screen for the virus, and they require frequent MRIs of the brain to look for asymptomatic PML. Now, if they get any of those all of a sudden confusion, ataxia, dysarthria, dysphagia, and PML suspected, then you immediately stop the medication and you should begin plasmapheresis and try and clear out the remaining medication sitting in the blood. Now, PML is sometimes compared to HIV-Associated Neurocognitive Disorder, also known as HAND. This is where HIV infects specifically microglia or even macrophages, which results in the release of toxic proteins. This can cause injury and inflammation to the CNS system. This is not a demyelinating syndrome. In fact, this typically is common or more common in HIV patients, hence the name. We typically see this in individuals with a CD4 count less than 200 or individuals who are very poor at taking their antiretroviral therapy or their heart treatment. Now, compared to PML, which is a progressive rapid onset, this will be more gradual onset, typically taking place over the course of months to years, with forgetfulness, altered mental status, dysphagia, ataxia. All the same symptoms that you may see in PML can also be seen in hand, but the time difference is different. The imaging is also unique comparatively to PML. In this case, we see atrophy, but instead of focal white matter changes, we'll have diffuse white matter changes due to the activation of the infection, HIV, affects the entire brain. As we can see here, we have all these white matter changes here that's affecting globally or the entire brain. Treatment for HIV-Associated Neurocognitive Disorder is going to be beginning or better usage of antiretroviral therapy. Here is a slide comparing the two of what we just covered. The next CNS demyelination disease that we'll talk about is osmotic demyelination disease, also sometimes known as central pontine myelinosis. Now, this is due to correction of hyponatremia too quickly, more specifically chronic hyponatremia. Chronic hyponatremia, or hyponatremia that has been present for greater than 48 hours, causes the brain cells to adapt by reducing their internal osmolytes to prevent swelling. So this typically occurs when the correction is greater than 8 to 10, really 8 milliequivalents per day. Now, what exactly happens? Well, let's say we are hyponatremic, 120 or somewhere around there, and I've reached a chronic hyponatremia, greater than 48 hours, which means that the amount of solute in my cells is equal to the amount of solutes in my blood. Things like to go from high to low. In the case here, this falls under the isotonic solution. Because there is equilibrium, there will be no movement. But if I correct sodium too quickly, which means my blood vessels now become hypertonic, a lot more sodium is there, things like to move from high to low. Now, it's hard for solutes like sodium to move, but it's extremely easy for that osmotic gradient to move water. In the case here, we have much more water because we have less solutes. We have more water here, so we have high water, and we have less water in my blood vessels, or low H2O, because there's more solute. So the percentage or the concentration is different. Things like to move from high to low, so high water concentration to low water concentration. All of this fluid is going to move out of my cells and into my blood vessels, and that causes shrinking. So in a hypertonic solution, when I correct it too quickly, we become hypertonic, the cells shrink and wrinkles, and then it can die. Specifically, this cellular dehydration and shrinkage can occur at oligodendrites, those myelin-producing cells in the pons, which are very, very sensitive and can become damaged, leading to demyelination. The symptoms that we'll see here are going to be associated with Osmotic Demyelination Syndrome. Seizures, dysarthria, dysphagia. You can also see locked-in syndrome, or damage to the ventral pons. This typically disrupts motor pathways controlling movement and speech, but it can spare the midbrain and the upper brainstem. And for this reason, this individual will be locked in with the inability to move their extremities and even their neck, but they will still be able to blink and move their eyes vertically. Since the midbrain and the upper brainstem are intact, that is the area that does blinking and the vertical eye movements. Please note that Osmotic Demyelination Syndrome, or central pontine myelinosis, typically takes place roughly 3 to 10 days after rapid correction of sodium. Now, the diagnosis is typically clinical, and the only indication for the MRI of the brain is if you are unsure of what the cause is here, if there is more things on your differential. Now, the treatment is none. The gold standard treatment is prophylactic treatment. Thus, the gold standard is no greater than 8 milliequivalents per liter of sodium correction in 24 hours. If my sodium is at 120, I cannot correct this then greater than 128 in the next 24 hours. The last disease will be Charcot-Marie-Tooth disease, or CMT disease. This is a peripheral neuropathy caused by mutations of the myelin in our axons. There are a large multitude of different CMT diseases, from type 1, type 2, all the way down to type X. But the most common type involves duplication of something known as the PMP22 gene, and this is an autosomal dominant type. The symptoms in this case will typically be distal muscle weakness. The feet are typically weaker than the hands in someone who is less than 20 years old, less than 20. You can also see neuropathy. Since the most common nerve affected is the peroneal nerve, you'll get foot drop. Of note, the second most common nerve affected is the ulnar nerve, in which you can get weakness of your hands. Pes cavus and hammer toes. This is what pes cavus looks like. You see this high arch here, and then of course you have a hammer toe here, a toe that is constantly flexed. This is due to the chronic neuropathy seen here. The diagnosis is typically clinical and confirmed with genetic studies. The big takeaway from this slide is if you see an individual with a peripheral neuropathy less than 20 years of age, and they have pes cavus and hammer toes, they are most likely telling you that this is Charcot-Marie-Tooth disorder or disease. In that case, they'll probably either want you to know that it is either autosomal dominant or it is due to duplication of PMP22. And that concludes this lecture on demyelination syndromes.